later if they're interested. So we're going to talk a little bit about ultrasound in resource limited settings. And I put that title out there on purpose because I think we've called this as several different things over the iterations of how we've started using ultrasound in settings that are outside of kind of high resource hospitals. We used to say tropical ultrasound. The issue with tropical, kind of tropical medicine approaches to ultrasound is that as we've progressed, there's a lot more that's not purely what you would call tropical infectious disease. It's just how you use ultrasound in settings where you don't have advanced imaging, you don't have other diagnostic tests. And so I wanted to start out with just some basic concepts around what ultrasound is in terms of how you'll encounter it in clinical settings as physicians in the US or in other high resource settings, and then how you might encounter it and use it in low resource settings. So why is that important? Well, it's important because when we talk about clinicians, so physicians, physician assistants, nurse practitioners, there's an ever-expanding use of ultrasound at the point of contact with the patient. So we call that point of care ultrasound, and it's gotten the unfortunate maybe abbreviation of POCUS, which sometimes makes people think of hocus pocus, but it truly isn't magic. It's just the idea that there is a difference between what you would call diagnostic ultrasound. So that's traditionally what you think about if you are going into a radiology suite, getting an ultrasound by an ultrasound tech, and then having that interpreted by a radiologist, and then the clinician who ordered the ultrasound, so your internal medicine, family medicine, anyone like that, would then use the results of that interpreted image to make clinical decisions. So point of care ultrasound is essentially taking all of those steps and then mashing them into one. So you're the doctor, you're the clinician at the bedside, the patient comes in, you yourself do the ultrasound, so you have to acquire the image. So you have to, for all of you who are probably, most of you are second years, some of you are first years, you're now spending time in the ultrasound center just getting a sense of how easy in some cases it is and how difficult in other cases it is to actually get an image that looks good. So that's step one. You have to get the image. Step two is you actually know how to interpret the image. So you actually then have to say, okay, well, based on this image, this is what I think it means, and then you have to integrate the image into the patient's presentation. So I found this. Does it fit with what the patient's presenting with? And then if that's the case, what do I do? So that is point of care ultrasound. So we're essentially doing ultrasound at the point of contact with the patient. Very different from a radiologist who's interpreting images remotely. Now, both are valuable. So it's not that one's better than the other. They're both valuable, but they are pretty different. So the history of point of care of ultrasound is essentially, this is the machine that most physicians kind of who started doing point of care ultrasound started out with. This is a big radiology machine. And at that time, it was really a matter of primarily ED physicians. And that's, I think, why we, as ED physicians, were often the ones who have done this the longest. In the middle of the night, there was no radiology tech. There was rarely a radiologist in-house, especially in smaller hospitals. And there were patients that would come in with where you would have questions about, do they have X or Y disease? Do they have gallstones? Do they have a dilated aortic aneurysm? Do they have a big DVT? And these were all questions that were actually relatively straightforward to answer by ultrasound during daytime hours, but were really hard to answer in the middle of the night. And some of them were life-altering decisions. So someone who has a ruptured aortic aneurysm, you can't really wait until the morning to do that. So clinicians started to figure out, hey, I can wheel the ultrasound down from the radiology suite. I can look at these and I can answer yes or no. Is the aorta dilated? Yes or no. Does a vein compress or not? Yes or no. Are there stones in the gallbladder? And so what point of care ultrasound came to be was a series of acquiring images and asking really yes or no questions. And that was the idea. You weren't doing a full diagnostic ultrasound. You weren't looking at every structure. You weren't interpreting the image in detail. You were really just asking a series of yes or no questions. Is there fluid in the abdomen? Yes or no. Is there fluid around the heart? Yes or no. And so that made it more dichotomous and a lot more straightforward because that was less subtle than what's the echo texture of the liver. And so the majority of what you'll encounter in the US when you're learning point of care ultrasound as a pediatrician, as internal medicine, no matter what specialty you go into, will still be around this principle of we do basic yes/no diagnostic questions. Now, that's really important and really helpful because most of the time, if we have more subtle questions in high resource settings, we can go and send them for a more complete ultrasound. The challenge becomes in places like this. So this is the hospital in Tanzania that I've spent quite a bit of time in. And Dr. Tipler can tell you about her experiences in Uganda, where the yes/no questions are a little more difficult because you don't have all of the tools at your disposal. You have more complicated patients who have had less medical care in general. You have typical disease, you have tropical diseases. You don't have advanced imaging techniques. You don't have CT, you don't have MRI. You may or may not have labs. And all of a sudden, the yes/no questions aren't quite enough to help you kind of make clinical decisions. This is another setting. So this is in Mali in West Africa. And this is a clinic that we were running in a schoolhouse. And again, there's no really at our disposal is the imaging technology that we've brought. And ultrasound is very portable. We could not bring an X-ray machine or a CT scanner. We had a microscope, we had some basic labs, so we could do some diagnostics, but you certainly can't get to the level of what you could get in a high resource setting. And so what that means from an ultrasound standpoint is you're starting to interpret images a little more nuanced than just yes or no questions. And I'm going to present some cases over the next 30 minutes or so that talk about some of that nuance and just kind of give you a flavor of what the next level of ultrasound kind of looks like in these in resource limited settings. Now, for the most part, I'm gonna base these cases in East Africa. So this is that little pin is in Mwanza, Tanzania, and that's where I've done most of my kind of tropical ultrasound work. This is on the shores of Lake Victoria, so that predisposes patients to certain types of tropical diseases, but also East Africa has a high rate of HIV and concomitant TB infection, and it is a fairly low resource area. Certainly, you don't see all of the tropical diseases, but there are a fair number of them there. So we're going to talk through a couple cases, and again, I can't see you guys, so you'll have to just chime in if you have any questions, but please ask questions as we go along. And my goal and my hope in the next 30 minutes is to just give you a sense of where you can go with ultrasound when you have limited other diagnostic capabilities and how your tropical medicine training can help you with that diagnostic approach. If you never go to tropical medicine, even if you go into a low resource setting in the United States, you're still going to use some of these same principles if you have an ultrasound. Right? So you're going to know your patient population, you're going to know the diseases that are present in your local area, and then you're going to make some clinical decisions, maybe with less resources than you might have at, Augusta University. So we'll go through case one. So case one is a pretty typical case that presented in this area. Young, relatively healthy male prior to this. He presents with massive hematemesis, so he's throwing up a lot of blood. And he comes into the emergency department initially, and he's admitted to the hospital. He's pale appearing. He has a big distended abdomen. He has an enlarged liver, a large spleen. He's hypotensive. He's tachycardic. He's hypoxic, and his hemoglobin is 4. And I would say on a day-to-day basis, about 3 or 4 of these patients were admitted every day. That upper GI, massive upper GI bleeds with significant anemia was an extremely common presentation. So there are multiple things that can actually cause this. And primarily this is driven by liver disease, although it can be peptic ulcer disease as well that can drive this. And this is his presentation. So he has a huge distended abdomen. You can see some of the, maybe a little bit of a caput medusa there. So big distended abdomen. And because we think liver disease is probably driving this to some extent, we do an ultrasound on it. So this is a right upper quadrant view, primarily looking at the liver. Can everyone see my pointer?
Yes.
Okay. So here we have liver. Now we're into the abdomen here. Here's gallbladder kind of sitting up there. And then this is portal vein here. And within the portal vein itself, you can actually see a little bit of echo density, so echo texture. So it looks a little bit Let's see, when we get back to the portal vein here. So if you look closely at the portal vein, you can see it's something that looks like it's moving within the portal vein. So that's actually portal blood flow. And that suggests that there's high portal pressures. So this is liver, here's our portal vein. And you can actually see if we look a little bit at a normal liver, so this is normal liver, that the portal vein is pretty small. So here's portal vein here, running through there. Portal vein's pretty small. These are hepatic veins here. The darker, bigger, darker ones are hepatic veins, but portal veins are pretty small. Here's another patient with very enlarged portal veins. So this black here is a big portal vein, and hopefully everyone can see all of these very bright white areas within the liver. These are not normal. This is actually fibrosis around portal structures, and this is very severe fibrosis around portal structures. So this is liver, and then all of these bright white areas are fibrosis around the liver. If you zoom in a little bit on these, so now I'm using a linear probe, and you zoom in a little bit, you can see again portal structures here, portal veins, and then all of this thick, what looks like almost a wall to the vessel here. All of this is very thick portal vein fibrosis. And this periportal fibrosis is pretty unique and really only occurs with one disease. And this patient has schistosomiasis. So schisto is an intestinal parasite, and you actually get it by exposure to contaminated water. And what happens is the parasite's life cycle kind of cycles between humans or animals. So there's a specific schisto species that occur in animals or in humans. And in these cases, essentially what the worm does is it sits in your intestine, kind of in the walls of your intestine. It lays eggs, and then you excrete the eggs. And then those eggs then infect snails. The snails, that's where the parasite develops in the snails. And then when the parasite becomes mature, it hatches out of the snails, and then it reinfects humans by penetrating through the skin. So swimming in contaminated water, you don't have to ingest the water, you just have to swim in it. Lake Victoria has a huge burden of schisto, and that's why you see a lot of schisto kind of in the areas around Lake Victoria. And this parasite actually, the whole life cycle really revolves around you excreting eggs and then the parasite reinfecting you. Now, the problem with that is that not all of the eggs get excreted. Some of the eggs get stuck in the bloodstream, and particularly because they mostly are in the intestines, they get stuck in the portal bloodstream, and those eggs get washed, instead of excreted out, they get washed back into the portal circulation. So if you think back to your anatomy and think about how the intestines are, the venous drainage to the intestines, right? Remember, all that you digest then goes into the venous system, and all that venous blood then goes back to the liver, and that's where the liver processes everything you ingest. And in those cases, those eggs get washed back into the portal circulation. Those eggs then get deposited around the portal circulation as the liver filters things, and as those eggs get deposited, then they cause fibrosis around the liver. And so you can see it leads to these eggs and that fibrosis. That fibrosis then can cause different patterns of very bright echotexture that appears in the liver. The more you are, the more severe the fibrosis becomes. Now, the problem with that fibrosis is you lose elasticity of the portal circulation. And so because you lose elasticity, your portal pressures get high. So here you can see in this image, again, the portal circulation draining from the inferior mesenteric veins, from the splenic vein, and all that should go into the liver. As portal pressures increase, you start to get backflow out of the portal circulation and back towards all of those veins that should be emptying into the portal circulation. So you get gastric varices, you get esophageal varices, and that is ultimately what leads to problems with upper GI bleeds. So this is an image of a normal portal circulation. So part of the reason I show this is, again, to kind of...
Oh, I was just going to tell you, I have to go admit 2 patients, so I have to sign out of the meeting, but you guys have a great session.
Thanks. Have a good day, Pam.
Bye, Dr. Tippler.
So why do I say all this? Well, because this again kind of comes into the realm of like, what does ultrasound do for you in these patients? And how do you use ultrasound in resource limited settings? And part of that has to do with going beyond just the yes or no, is the portal vein dilated? And thinking actually through knowing your ultrasound anatomy, knowing your regular anatomy. So this is a still image right now of the liver, as you can see, liver here. And then here's our spine. This is aorta. This is celiac trunk here coming off the aorta. This is inferior vena cava here. So this is a pretty complex anatomical ultrasound image. And this goes well beyond what we would teach you in point of care ultrasound, because most of the time we are teaching you identify one structure and then make a yes or no decision. And that is, again, really appropriate in high resource settings where there are radiologists who spend a lot of time looking at the anatomy of all of these vessels. But knowing these relationships and being able to identify the portal vein, for example, in its relation to the liver, the IVC, the aorta is really helpful. So again, here's normal. So we can trace that portal vein, and that we know that portal vein actually goes into the splenic vein. Here you can see the SMA here. And this again there's lots of blood vessels here, and this gets pretty complicated. And as you do more ultrasound in settings where you don't have anyone else to kind of double check you, you start to become better at being able to work through this and sort through what's the relevant anatomy I need to know. So here's a normal portal vein, and here's an example of a very distended. So hopefully everyone can tell the difference. This is the portal vein as well. Massively dilated portal vein, enormous high portal pressures. Again, those high portal pressures are caused by all of that fibrosis. That these eggs then induce this fibrosis, and it causes the portal veins to be less distensible. So if you have more rigid structures, they become higher pressure. And that then causes backflow into all of the bridging veins or all of the peripheral veins around the stomach, around the esophagus. So that's how you get esophageal varices, high portal pressures. See some of these varices actually, if you look carefully here, you can start to see this is actually a variceal vein that's going to go up into the esophagus. And so these high pressure, very thin walled veins are what cause varices and what cause risk of then having massive upper GI bleeds. So this is a patient where we can say, okay, I can see his high portal pressures, I can see esophageal varices, I have a reasonable suspicion based on ultrasound that he has intestinal schistosomiasis, and you can make diagnostic decisions and treatment approaches based on just looking at the ultrasound and just getting the history. So you don't have to do any other testing in these patients. Ideally, in a high resource setting, you would be able to do more testing, but this alone is enough to drive you to kind of make an initial management decision with these patients. Does anyone have questions about that?
I have a question in the chat.
Okay.
Somebody says, how can you distinguish between a dilated portal vein and the gallbladder?
Awesome. Yeah. So again, so good question. So the dilated portal veins actually, again, this goes back to this image here, which is the portal structure should be contiguous with all of the other anatomic vessels they connect with. So here we see portal veins. So how do I know that's not the gallbladder? Well, I can trace the portal vein back to where it comes out of the liver. So the gallbladder shouldn't exit the liver and cross the midline. But I can see the portal vein crossing the midline and then connecting with a splenic vein here. And here's my marker. How do I know it's the portal vein? Well, the portal vein and portal-splenic confluence should be connecting above the SMA. So there's portal vein, here's portal vein, here's splenic vein, portal-splenic confluence. My SMA is going to come in right there. So here's my SMA. How do I know it's the SMA? Well, I just saw it come off the aorta. Aorta, SMA, portal vein, and I can trace that all the way back into the portal structures. Here's my IVC. Here's something else connecting the IVC over here. So here's the aorta, and then that's IVC, and then there's a vessel in between those. So the only vessel that goes in between the SMA and the aorta is the left renal vein. So here's the left renal vein coming between the SMA and the aorta, emptying into the IVC. Question, and it's actually, again, kind of where knowing your anatomy really well, and I say this all the time to my residents and med students and things like that, is, it's surprising to me how much of, like, I had to relearn some of this complex anatomy that I learned in first year of medical school, because it comes back and haunts me a lot now, is knowing the relationship between the SMA, the portal vein, the splenic vein, the inferior mesenteric veins, the aorta, the spine. All those things actually are really important, because I can now make decisions about what structures are, because I know how they're related anatomically. So that's how I know that's the portal vein, because I can trace it all the way out to the splenic vein and then trace it all the way back. In this case, again, here, I can trace this all the way, and I didn't do it fully in this video, but I can trace this portal vein all the way out, and then if I traced it all the way here, it would actually connect to the splenic vein here. And the appearance of this, because it is a circle, so any tubular structure appears like a circle in short axis, and then appears as a long tube in long axis. The gallbladder tends to have more of a teardrop appearance in most patients, and it doesn't connect with other vascular structures. But in one image, it can be a little bit subtle. But that's where one video doesn't necessarily capture all of the ultrasound images you would obtain if you were at the bedside. So that's the conclusion of our first case. So we had a patient with massive upper GI bleed, multiple possible etiologies. Ultrasound shows us portal hypertension. It shows very, very specific signs of a intestinal parasite that's quite common in the region, and we can make management decisions based on that. Again, not really a yes or no question. It's a little bit more knowing your anatomy, knowing your tropical medicine, knowing the patient's location, knowing a little bit about physiology. All those things kind of come into play when you're doing this, especially when you don't have much other backup. This is a different patient. This is, again, a liver ultrasound, and I included this because this is a very different pathology, but can present very similarly. So again, this is black. So black is fluid by ultrasound. So lots of fluid, and we have a liver here. The liver looks very different. Hopefully everyone kind of says, well, that looks really different than the prior liver. And this is actually a cirrhotic liver. So over time, cirrhosis causes the liver to shrink. It becomes very rough, kind of this lumpy, bumpy surface, and you lose all the vasculature, because the liver actually the whole liver itself kind of shrinks down, and you can't really, there are some still vessels here, but there's a lot more just kind of that cirrhotic changes to the liver, and so you can't see the vasculature. This actually also, because everything's compressed, leads to increased portal pressures as well. And so these patients are also at risk of esophageal varices from a very different pathophysiology. In this case, it's not a parasitic infection, it's actually the entire liver itself is becoming cirrhotic. So your approach in terms of treating the parasitic disease and how you're going to then manage the upper GI bleed will overlap to some extent, but it will be different just based on the fact that this is the end presentation could be different, but the underlying cause isn't the same. So let's go to another case. And this is another tropical medicine case. This is actually from Peru. This is a 45-year-old male who comes in with a year of progressive right upper quadrant pain, fever, some jaundice, so also suspected liver pathology. And his vital signs actually look pretty good, but he's had over a year of symptoms. And by ultrasound, when you look at his liver, you see something very different than the last patient. So you see this large structure here, some black, so some fluid in it. It actually, if you look closely, it looks pretty well circumscribed. So it actually looks pretty circular. And there's some internal septation. So it's not a simple fluid-filled structure because it actually has complex material within. And the liver itself is over here. You actually can catch a little bit of the portal vein here. So here's a little bit of the liver. Here's this big cystic structure that's kind of pushing other portal structures out of the way. Now we're in Peru, we're in South America. We have a large complex cyst within the liver, and there aren't a lot of things that have this appearance in that part of the world with this type of presentation that's occurred over a year. And this is cystic echinococosis. And what that is again, another parasite. The parasites probably give you the most interesting ultrasound findings. And this is, again, a parasite that's actually primarily life cycle is between animals, so mostly canines or other carnivores, and livestock. So in general, this is supposed to be an intestinal worm, tapeworm, that lives within the intestines of dogs or other predators. It doesn't actually cause the dogs any real problems. It just hangs out in the intestines and lives a parasite life, and does, the animals don't really mind that much. What happens then is the worms then lay eggs, the dogs excrete the eggs, then you have sheep, pigs, cows that eat those eggs, or eat the dog poop, basically, that happens, or the eggs that happen to get excreted in the dog poop. And then what they develop cysts in the liver, the spleen, the kidneys, things like that. And then when those animals are slaughtered, and this is often how it goes, is these are in areas where there's a lot of livestock being raised. Those infected liver cysts or heart or cysts or lung cysts, then those parts of the animal often get given to the dogs to eat, and then they eat the cysts. They then become infected with the tapeworm. The tapeworm then lives in their intestines, and the life cycle persists. Now the problem is that what happens is when we eat the dog poop, so if humans eat dog poop, then we get the worms, but the worms then develop in our liver or our lungs or our spleen or our kidneys. So how do you end up eating dog poop? Well, primarily in settings where there's a lot of livestock, there's a lot of dogs, and there's a lot of kids that run around. The kids run around with the dogs poop, the dogs lick their butt, and then they lick the kids, and then the kids basically get the worms, get the eggs, based on just that close interaction between humans and dogs. So once you get those cysts, they actually are fairly large. And here's a kind of macroscopic surgical picture of a large liver cyst. And so they are, can get 6, 7, 8, 10 centimeters across. And if you take a cross section of those and look microscopically, what you can see at the bottom is you have liver tissue at the very bottom, and then you get this inflammatory layer, and then you get this very thick-walled cyst. And then within the cyst itself, there are all these little capsules, and those capsules are made up of hundreds of parasitic eggs. And you can see those little arrows there that say single protoscolices, and that is one parasite. So each single protoscolices is theoretically capable of infecting another animal. So you get these large cysts, and here's another image where you can see those large cysts are not subtle when you're looking, especially at the liver. Now, why do they end up mostly in the liver? Again, it goes back to that same anatomy, right? So when you ingest something like an egg, most of the way that it makes its way into your circulation is through the portal circulation. So those eggs end up in your intestines, and then they end up ending up into the portal circulation. They make their way through the portal circulation, and then they get filtered out in the liver. And so that's where a lot of these parasites end up, is in the liver. They can also end up in other places as well. If they get into the circulation, they can go to the brain, they can go to the kidneys, they can go to the lungs. Again, any areas where there's high amounts of vascular flow is where those parasites tend to live. But the liver is by and large the most common place. So these liver cysts exist in a set of transitions as they develop. And essentially they can appear in multiple different ways as the cysts age. So you get infected with a parasite, that cyst will develop over time. And it can develop from an active stage where there's lots of living parasites, and it can end up, even without treatment, into an inactive stage where all the parasites essentially die within the cyst. Over time, if you have a cyst for 20 years and nothing else happens, those parasites can't live for 20 years within the cyst. They're waiting to end up getting excised from whatever animal they're in, and then keep their life cycle going by getting eaten by a dog. So if they just live in your liver forever, they will die. Now, the problem is, if the cyst ruptures before all the parasites die, you can actually, those parasites within the cyst can reinfect you. And so the biggest concern is those cysts don't always stay intact. But by ultrasound, you can kind of judge where the cyst is in terms of its life cycle. Is it pretty active, in transition from being active to dying? And that activity can help you decide what treatment approach you're going to do. So this is just another illustration of that same thing. You have a pretty simple, large kind of black cyst with thick walls, but nothing else in the liver. And then over time, it can develop into these different stages. And they actually have specific names, which isn't really worth memorizing for you, but just hopefully giving you a sense of these all look very different by ultrasound. And in about 20% of normal cysts will die on their own spontaneously within 2 years. But the remainder of those can stay active for quite a bit longer, and if they rupture, can cause complications. And so, or just mass effect. So in our patient that we talked about, that I presented, he wasn't having complications from the cyst rupturing. It was just that cyst was now compressing the portal circulation, the biliary the bile ducts, and he was getting mass effect. As the liver was overtaken by the cyst, all the liver functions were becoming a lot more difficult just because of pressure on the portal circulation and the biliary tree. So here we have multiple stages of cysts, and the diagnostic value of this is that your treatment approach is going to be different. If the cyst is totally dead, then you don't need to treat those patients. If the cyst is highly active, then you need a more aggressive treatment. If the cyst is in the early stages, then you can do something. You can actually puncture the cyst itself. And this is because the cysts that are kind of in the early stages that don't have a lot of loculations or septations, getting to those parasites is pretty straightforward. If you put a needle into the middle of the cyst, you can actually inject some fluid in there that will kill the parasites. That's either alcohol or hypertonic, so highly concentrated saline will kill those cysts. And this is actually an ultrasound image. So this is done under ultrasound guidance. And here we see a big cyst. And if you look at the top of the screen here, you can get a sense that there's something coming in through the abdominal wall, through the liver. And this is actually a needle. So this is the cyst, and they're guiding a needle through the liver into the cyst wall. Now, once they get into the cyst wall, and you can see here's the needle tip here. So now they're in the cyst itself. They've basically put a needle through the abdomen, through the liver, into the cyst, and their needle here, and they can suck out a bunch of that fluid. And then once you suck out some of that fluid, you can see the cyst is pretty collapsed because we sucked out all that fluid. And then you can instill. Then once you've sucked out all the cyst fluid, you can actually, and here they are and then you can instill something that will kill all the parasites. And this works very well if the cyst is in a relatively early stage. The problem is, as the cysts develop, you need to then go to chemotherapy options, and that's antiparasitic medications. So again, another case where this is a lot more subtle and complex than just kind of a yes, no, is there a cyst there? You're making decisions based on the appearance of the cyst and the stage of the cyst, and then making treatment decisions based on what stage of the cyst you think they're in. And then in some cases, you're using ultrasound as the therapeutic modality as well. All right, let's go on to case 3. So those are probably the most complex, well, that's 2 of the most complex tropical diseases that you can really use ultrasound very effectively for. This is another very common presentation, which is cardiac conditions in low resource settings. And there are, just like in high resource settings, there's lots and lots of different cardiac conditions that can present. Some in kids, most in adults. This is a 17-year-old male that had come in with no past medical history and came in with increasing abdominal swelling. He was tachycardic, hypotensive, and he had An irregular heartbeat. He had a systolic murmur that was heard best at the apex. His lungs didn't have any crackles. It didn't sound like he was fluid overloaded. He had a huge distended abdomen, but no tenderness to the abdomen. And he had clear ascites, but really no extremity edema. And this is the typical appearance of these patients. These are two different patients, but same type of presentation where you see massive abdominal distension. But with cardiac conditions, pretty unusual to have isolated abdominal distension and abdominal ascites with no swelling of the extremities. And this is a pretty well-known cardiac condition. Up on the left, you can see a normal heart, and this is the patient's heart. So in this case, we see some fluid around the heart. We see this would be the left ventricle, and this would be the left atrium. Here's our left ventricle here. Here's our left atrium. And this is actually a very massively dilated right atrium. So big, massively dilated right atrium, whereas normally the right atrium would be about this size. So in this case, big dilated right atrium. And there's really only one condition that gives this appearance in young patients, especially in Africa. And this is called endomyocardial fibrosis. And it's something we probably never talk about in medical school because we don't see this ever in high resource settings. What exactly causes this is still a little bit unclear. It's thought to be an eosinophilic reaction to probably parasitic infections. And over time, what it does is it causes fibrosis of the ventricle. And that progressive fibrosis of the ventricle then causes increased pressure within the atrium. And you get these massively dilated atria because of the progressive fibrosis of the ventricle. And that leads to this pretty characteristic finding of kind of a non-existent ventricle with a massively dilated atrium. So you can see here is another picture where you can see that right ventricle is starting to get obliterated. You can't really see much fluid in that right ventricle, and the right atrium is starting to dilate. This is another image of the same thing of a patient. So on the top left, you can see a normal view, and on the bottom right, you can see a fibrotic right ventricle. And so that's why there's all this bright white material with where the right ventricle should be. And you're starting to see this very enlarged right atrium. That's that big fluid-filled circular structure here. This is an apical 4-chamber view. So we're looking at all 4 chambers. Again, on that left side of the image, that's the fibrotic right ventricle. And below that, you can see this starting to be a very large and massively dilated right atrium. This is kind of the end stage of this disease. And this is where basically you completely lose the right ventricle in this case. And this actual structure is the right atrium. So massively dilated right atrium. You can actually see here where the IVC should be emptying into, you can't even really see that. You see that left side at all. You really just see right atrium, and you can see where the IVC kind of is emptying into that. So this is another disease process, again, where you're putting together the pieces, kind of going through knowing about tropical infectious disease, but also being able to interpret very bizarre images and putting that using your anatomy, so knowing where the IVC is, knowing where the liver is, knowing that that empties into the right atrium, knowing all of those things, you're adding all of your components of your history, your physical, your ultrasound together to make the best diagnostic decision you can with limited information. So ideally, in high resource settings, you'd have a lot more at your disposal, but in these low resource settings, you're going to make treatment decisions based, again, on, okay, this is the presentation, this is typical for this type of disease. My ultrasound is also consistent with this approach. This is based on this is what I think is most likely going on, and this is what I'm going to do in terms of treatment. So again, moving well beyond the kind of traditional, is there fluid, yes or no? Is something dilated, yes or no? Now, that's not to say that what we have done traditionally in point-of-care ultrasound isn't valuable or isn't used in resource-limited settings. In fact, trauma is probably one of the most common diseases in all resources, high resource, low resource. And the prototypical example of a trauma ultrasound is the FAST exam. And so this was one of the first exams used in all of point of care ultrasound. And this again was because you have patients coming in who have massive trauma and you want to know, are they bleeding internally? So are they bleeding? Do they have bleeding around their heart? Do they have bleeding around their lungs? Do they have bleeding into their peritoneum? And the easiest way to do that rapidly at the bedside was to put an ultrasound probe on them. And this is true in any resource setting. So here's our next patient, who's a 22-year-old male. He arrives via ambulance, or what is often kind of serves as ambulances in a lot of settings, which is just a passerby who happens to have a truck or a car that they can bring the patient to the hospital. And he was riding his motorcycle. He was hit by a truck at a high rate of speed, and he was unresponsive, has an obvious fever with exposed bone. He's hypotensive, he's tachycardic. And we have taught you all the FAST exam, or if you haven't been taught it yet as a first year, you will be taught the FAST exam. And the FAST exam was really designed to answer these exact questions. Okay, this patient's been in a significant blunt trauma. Where is there, if they're blood, are they bleeding in places where we need to operate on them? And essentially where that blood can be from a blunt trauma standpoint that's clinically important is around the heart, in the thoracic cavity, or in the peritoneal cavity. And so the traditional 4 FAST views, right upper quadrant, left upper quadrant, subxiphoid, and suprapubic, help you determine is there free fluid in those areas. So here is a ultrasound of his bladder. You can actually see this is fluid-filled urine in the bladder, and then you can start to see there's fluid outside the bladder here. So black fluid outside the bladder. If we go to the normal right upper quadrant view, so if in a normal patient who has a negative FAST, we would put the probe here in the right upper quadrant, and we look for free fluid here in between the liver and the spleen. So Morrison's pouch here, we look for free fluid. And if we do that in this patient, we can look at the kidney, we can look at the liver, and we can see there's some free fluid here and some free fluid here. So it can be obvious, it can be subtle. This is a subtle amount of free fluid. This is a little bit more of an obvious amount of free fluid, so a massive amount of free fluid. Liver pushed up here, massive amount of free fluid. Now in trauma patients, most of the time, you'll see smaller amounts. So you'll see something along the lines of this, because haven't had enough time to bleed 2 or 3 liters into their abdomen if they're still alive. If they had bled enough, this is probably 5 or 6 liters of ascites. So this isn't a trauma patient, but this is a patient, again, with free fluid in the abdomen. And if you bleed 5, 6, 7 liters of blood into your abdomen and you don't get blood replacement, then you don't usually. So here's free fluid in the abdomen. This is again, right upper quadrant here. Now we're looking at the liver. We're looking at spine. We're looking at fluid, not in the abdominal cavity, but in the right upper quadrant above the liver. So this is into the right hemithorax. And so this is a patient who also has large amounts of free fluid in the thoracic cavity. In the face of trauma, we would certainly be concerned about a right hemothorax. So at the bedside, this really helps you guide your interventions. Where do you think the blood is? And what is the next step? So if they have a lot of blood in their chest cavity, then putting a chest tube in to drain that blood, to re-expand the lung, can go a long way to stabilizing them enough that you can start giving them blood transfusions. So this is what I would call a pretty traditional point of care ultrasound approach. So some complex things, but some pretty straightforward, common items that we see and use every day in clinical settings. If you never see a trauma patient and you go into pediatrics medicine, there's still a lot of value in being able to do something like this, because as I've told you before, and as you will continue to learn as you do more ultrasounds, any black that's in free spaces, any of this black can be any type of fluid. So this could be pus, it can be blood, it can be pleural effusion, it can be ascites if it's in the abdomen. And you can't really tell the difference. There's some subtle clues, but in general, you can't really tell the difference by ultrasound which of those things it is. And so you're using your history and your physical to help guide you. So in a case of a patient with history of lung cancer who comes in with this large pleural effusion, we're going to assume that that effusion is due to his cancer, not to an acute trauma. And if you're in internal medicine, you're trying to decide, do I need to do a thoracentesis and tap that fluid? Having an ultrasound at the bedside be able to tell you how much fluid there is in there, or having an ultrasound tell you how much ascites there is somewhere, can help you quite a bit in kind of making those next stage decisions, again, in almost any setting. I'm going to skip a couple of these and go to another very common presentation. So this is similar type of patient in some ways with a very different initial presentation. So this is a 25-year-old female who presents with abdominal pain. Last period was 5 weeks ago and comes in hypotensive, bradycardic, and pale, diaphoretic, says for sure she's not pregnant, which often means that patients protest that there's no way they could be pregnant. Oftentimes that increases your suspicion that there is a chance that they could be pregnant. She has a non-distended abdomen, which is very tender. And so in a young female who comes in shock and looks unwell, the concern is for a possible ectopic pregnancy, among other things, especially if they don't have a history of trauma. And so we're going to use these same views to look for free fluid again in the abdomen. Not, in this case, free fluid that's caused by trauma, but a ruptured ectopic that's also going to cause bleeding into the peritoneum. And here you can see quite a bit of free fluid. Here's the liver, free fluid around the liver in the right upper quadrant. If we go into the pelvis, we can see here's the bladder, here's uterus, and we can see a bunch of free fluid around the uterus as well. And so 25-year-old female, potentially pregnant, lots of free fluid. The two most likely things would be either a ruptured ovarian cyst causing significant blood loss or a ruptured ectopic pregnancy. Again, at the bedside with an ultrasound plus minus a pregnancy test. Again, pregnancy test would be really helpful as to making a definitive diagnosis. But either way, this patient who's bleeding massively into the abdomen needs an exploratory laparotomy to find that bleeding source. Now, in some cases, and it's not very common, but in some cases, ultrasound will actually give you the answer. So in this case, this is a patient I saw in Tanzania, actually, in the emergency department, who had the very similar presentation, pale, diaphoretic, no obvious external blood loss, but a hemoglobin of 4. And here is the actual ectopic. So here's the uterus, here's the fetus, here's the surrounding inflammatory tissue around that fetus, and this fetus is supposed to be in the uterus. And so this isn't clear ectopic. This is actually a fetus with a heartbeat and very, very high risk. You can start to see some free fluid here as well. And so this is something we would do in any setting. So emergency department anywhere would use this diagnostic tool. Use an ultrasound. Is there free fluid in the abdomen? Yes, no. And based on that free fluid, yes or no, would then, based on the presentation, say, okay, well, if they're young and they're female and we suspect ectopic and we see free fluid, we think that's probably a ruptured ectopic. If they are recently in a car accident and they have severe belly pain and they have obvious signs of trauma, then we're going to think that's free fluid that's bleeding because of a intra-abdominal injury. So different presentations can lead to similar appearances by ultrasound, and you're going to make clinical decisions again based on that history, the exam, but also the ultrasound. So these two cases are pretty classic yes/no cases. I'm going to end with our last case of a 35-year-old male who presents with a history of abdominal pain and a history of HIV. And the reason we'll end here is just this is a good example of how some of the complexity of those first two cases that I showed you, where you have a very complex disease process where you have to do a lot more than answer yes or no questions, can be combined with the approach of I have limited ultrasound skills, or I have not been trained in extreme, all this infectious tropical medicine, but we can put those two together and kind of answer some yes or no questions and help us make better medical decisions at the point of contact. And this was and still is a very common problem in many areas where there's high HIV prevalence and fairly low resources, where you have a patient who comes in and they have a history of HIV. Either they are being treated and they've been lost to follow-up, or they haven't been able to afford their medications, or something else has happened where they aren't routinely taking HIV medications. And they come in with fever and weight loss, some cough, some night sweats, and the question becomes, do they have TB on top of their HIV? And this is an older slide, but still very true, which is in areas where there's high HIV prevalence, we see high TB prevalence. And HIV and TB really go together hand in hand, because as you compromise the immune system, you're less able to fight off TB, you're less able to fight off mycobacterial infections, and your risk of acquiring TB or having recurrent TB is much higher. Now, the problem with that is you can have patients that present with HIV and fever and weight loss, and if they have this X-ray, which is there's this big infiltrate on the right upper lobe, which is pretty classic for TB, or you can have this X-ray where you can see actual gone complexes. If they present, then it's pretty straightforward to say, well, if you have a history of HIV and you have TB symptoms and you have TB appearance on your chest X-ray, I should treat you for TB. Or this is another example, this is miliary TB. So all of these are pretty straightforward. The problem becomes if you have similar patients, so they present history of HIV, fever, weight loss, cough, but their X-ray looks clear. And Tom Heller, who was working quite a bit in South Africa, who was trying to design, okay, well, how can I assist medical decision-making in these patients where they still sound like they have TB, but we don't want to commit them to 6 months of TB therapy without some type of diagnostic testing. We know they have HIV, but the traditional diagnostic approaches to TB at that time were pretty cumbersome and not very accurate. And so what he did was combine the ideas of a fast exam, so specific focal views, and looking for specific findings. So so these are looking for effusion, so fluid, either fluid around the heart, fluid in the thoracic cavity, fluid in the abdominal cavity, and then looking specifically for signs of lymphadenopathy, which is very common in TB patients. So here is an abdominal ultrasound. Here's the aorta. And on this abdominal ultrasound, you can actually see all these little black dots here are lymph nodes, enlarged abdominal lymph nodes. This is a normal ultrasound of an aorta. Here's the aorta, here's the SMA coming off, here's the celiac axis. And you can see actually there's no lymphadenopathy here. So there's none of those little black dots that appear there. There are lymph nodes that live in these spaces. They're just, if they're not inflamed, you can't see them by ultrasound. But as they get inflamed, they become much more apparent. So here's a big lymph node here, multiple lymph nodes here. Here's another example. This is a cross section where we're looking at the aorta in cross section. Here's the spine, here's the aorta, here's the IVC, here's the portal vein here, again, portal vein, portal splenic confluence, SMA, and you can see liver here, and that's about it. Here's the same ultrasound with lymphadenopathy, where we can see the spine, we can see the aorta, and then all of this is lymphadenopathy. So massive abdominal lymphadenopathy is not exclusive to TB, but pretty characteristic of TB. Here you can see all those lymph nodes there. Another thing you can see quite often in TB is effusion, so fluid. So this is again ascites in this case, driven not by portal hypertension, but driven by the abdominal TB infection. You can also see lesions in the spleen. This is normal appearance of a spleen. This is actually a enlarged spleen, so it's actually not normal size, but normal echo texture. So, and as TB infects the spleen, you can see these lesions. So hopefully everyone can see that spleen looks a little bit moth-eaten. If you look at this video, you can see all of these little lesions, kind of black lesions within the spleen itself. This is a zoomed in image of the same thing. where all of these are little TB microabscesses. So these are all little mycobacterial abscesses that get lodged in the spleen. And when you combine these types of findings, so do we see lymphadenopathy, yes or no? Do we see ascites, yes or no? And I would add to this, do you see fluid in the pleural space, so pleural effusions, yes or no? Pericardial effusions, yes or no? Then you can start using these to say, well, what is the risk of having abdominal TB or disseminated tuberculosis in the face of HIV? And the more of these findings you have, the more likely your risk of having extrapulmonary, so TB that's found outside of the lungs. And that turns out to be very valuable in the HIV patients, especially, that don't mount a traditional inflammatory response to TB. So I'm going to end the presentation there and just take a minute or two to see if anyone has any questions. And I have lots more cases, so we can kind of pick up at some point if people are interested in getting more of that. But my hope was, with a couple of those cases, just to give you a sense of the range of what ultrasound is used for in resource-limited settings and in a tropical medicine application. So some things that are very complex and that require that you have a little more advanced training in ultrasound. Some things that are very straightforward that you guys are learning now in medical school in terms of just identifying free fluid and then using your clinical context to help you make decisions. And then seeing a case where you combine those two, so you can know what an infectious disease does and then be able to identify a couple key elements of a little bit of free fluid, some lymphadenopathy, which if you're seeing it for the first time seems a little confusing, but after a couple training sessions, and there's actually data on this, a couple training sessions, people get pretty good at finding those things, and that can help you really, again, make clinical decisions about these HIV patients that are significantly decompensated and have a high risk of TB. All right.
This was great, Dr. Kamenstein. Thank you.
Sure. Questions at all?
Yeah. Thank you so much. And
Yeah.
I think we would probably next semester want to have another meeting
Okay.
like this, because I know that M1s were interested in coming,
Yeah.
but like you said, it was a busy week for them. But yeah, thank you so much.
Sure. And I hope it just, if I were, I know that as a first or second year medical student, if I saw all of these images, I would feel pretty overwhelmed. Like there's no way I would ever be able to interpret any of this. And my hope wasn't to make you should not be able to go out and then interpret all of these images. My hope with this lecture was just to give you a sense of how this is being used in the real world right now, being used for very complex things by clinicians in those settings, used for very, very straightforward things as well. And there's just so much that you can do with an ultrasound if you want to, that I think there's the applications and the ability to do that is pretty exciting. And I get really excited about doing this and teaching other people how to do this, especially when they don't have access to other elements of CT scans and MRIs and labs, because you can make pretty good clinical decisions. They're not always perfect, but you can make pretty good clinical decisions just with knowing the history and being able to look at some images. But yeah, I'll be happy to do this again. And as I said, I have infinite number of cases, so we can go through a bunch more. Next time I can run through some of these other cases and go through some of the basics again for anyone who's interested.
Yeah, thank you so much. And also, if you could send me the recording, if I could send it out to our listserv, that'd be awesome. Yeah,
I will. How about this? I think it should post on this meeting, but if not, I'll just send it. Do you guys know how to use the Microsoft Stream? If not, I'll send it.
No, sorry.
Okay. Yeah, I'll send the recording to you guys, and then you should be able to download it.
All right. Thank you so much.
Sure. Sorry, this has to be remote. It's definitely a little bit more. Some of these images I know don't come across as well if it's kind of digital. So someday we'll be able to do this again in person, and I can walk through the images where they're a little more clear.
Yeah, I think it was good though. I was able to follow it still. So
cool.
yeah, super appreciated.
Yeah, definitely. All right, take care, everyone. Have a good week, and yeah, stay safe.
Thank you. Bye.
Right.
Thank you so much. Have a great week.